Hello, friends. This is Rob Chatburn. I will be your presenter today. And today we're going to take a look at how inspiratory effort affects work and affects, in particular, plateau pressure during pressure control modes. These are the disclosures, our typical disclosure page for Dr. Mireles and myself. Ground rules, just to repeat once again, please keep your microphone muted unless you want to ask a question. You can also raise your hand and you can also put something in the chat. There are CRCEs available for respiratory therapists. Okay, so let's dive into this. Here's a question for you. How does plateau pressure, or what does plateau pressure tell us about volume delivery in the pressure control modes? And we're going to review this briefly because oftentimes I think people assume that when you're in pressure control, you set the plateau pressure and it's always the same. It doesn't matter what happens with the patient, but that is not the case. And the way we're going to explore this today is I'm going to show you a series of waveforms that are idealized, meaning that I got them from a simulator. So there's no noise and they're perfectly shaped, just as you'd expect them to be. So here we're seeing pressure waveform at the top. You see it's pressure control because there's a constant inspiratory pressure. Looking at the flow waveform, we see that it decays exponentially very nicely. And this is going to be a passive inspiration because the flow waveform is undistorted. Also, we see a vertical dotted line that represents an inspiratory hold. It's considered a manual inspiratory hold, if you will. And in this case, we see that flow decays to zero just before the inspiratory hold is instituted. And what that means is that a passive tidal volume will reach its maximum value by the time flow decays to zero. And what is that tidal volume? Well, it's just the compliance times the change in pressure. Change in pressure is the set pip minus the set peep. And in this situation, the plateau pressure will be equal to the set inspiratory target pressure above PEEP, just as you would expect. Now, however, we might have a situation where flow does not reach zero at the time of the inspiratory pause. This could happen, again, this is a passive inspiration, but this is going to happen for a patient with a long time constant. And why? What does a long time constant tell us? Well, it tells us that generally you have a high inspiratory resistance. So if we see this pattern, then we know that because flow didn't have enough time to reach zero before the inspiratory hold, then our passive tidal volume is going to be less than its maximum value of compliance times delta P. And as a result of that, when we do the inspiratory hold, the plateau pressure will be less than the target inspiratory pressure. Now, the opposite could happen. We can see that flow during an active inspiration, and we see it's active because this red curve here represents muscle pressure. So the patient's making an inspiratory effort here, and because of that inspiratory effort, the flow waveform will be distorted upwards. It'll be increased at every point. And that flow waveform could be virtually anything depending on the shape of the muscle pressure waveform. In this case, we see the flow increases above what we would expect for a passive patient. Then the patient starts to relax. Flow goes a little bit below zero just before the inspiratory pause is set. Now, because this P-mus is adding to the airway pressure from the ventilator, P-mus adds to P-vent. Now we have an active tidal volume that's larger than you would get with a passive tidal volume. So it can be larger than you would expect from compliance times delta P. And as a result, when the patient relaxes and we get a nice plateau pressure, the plateau pressure will be higher than the set peak inspiratory target pressure. So those are three different situations that you want to be aware of in ideal situations, so that when we look at real pressure waveforms, we'll be able to understand what's going on. Okay, so let's jump into this. Here we have a screenshot of a ventilator delivering a mode that they call APV-CMV. So I'm going to ask you the typical question: what is the tag for this? And where do you look to figure out what the tag is? I'll give you about 30 seconds to a minute to start thinking about this. Hopefully somebody out there will make some guesses, and don't be afraid to get it wrong, because this one's going to be a little bit complicated. Anything in the chat yet, Ari?
Yes. Arsal
Very good.
already answered PC-CMVa.
I like that. And how do we know that? Well, here's a couple of clues. Well, we know it's pressure control because we look at the flow waveform, right? That's where our eyes go first. You say the flow waveform is highly irregular. If it was volume control, it would be some kind of regular geometric shape. It's highly irregular, and in this case, it's even deformed, so it's concave downward. And so we know that there's some active inspiratory effort on top of the pressure control. We see that these little triangles here represent that this is being pressure triggered. And we see that every single inspiratory time seems to be the same, even though there's a variable inspiratory effort. So, yeah.
Rob, the pink triangle says that it's flow trigger, I think.
Oops. All right. Yeah, the color of the triangle represents the variable, not where the triangle appears. So this is magenta. So this is the shape of the flow. I mean, the color of the flow waveform says it's flow triggering. If these were yellow triangles, then it would be pressure triggering. And there's one for the automatic triggering. I can't remember what color that is. Is that blue, Ari?
Blue is for IntelliSync.
IntelliSync, yeah. So that adjusts the triggering itself. So anyways, the point here is we know every breath is mandatory, because despite the fact that it's patient triggered, it's machine cycled by a preset inspiratory time. Even though we can't see the inspiratory time setting here, we can see that the inspiratory time is virtually the same for every single breath. Very good. So, and how do we know it's adaptive targeting? Well, you could have looked this up in the ventilator mode map and it would have told you that. But here's your clue over here. You have a tidal volume setting at the target tidal volume in a pressure control mode. So that's a dead giveaway that the ventilator is attempting to adjust the inspiratory pressure to get this tidal volume on average. And we see that every tidal volume is different, but on average, it's right around 450. Okay, next, what's the load? What do we think about the load here?
Megan is answering PMAS.
PMAS, yeah. We certainly see evidence of PMAS. We already said that. On the inspiratory inspiratory flow waveform is deformed upwards. That means there's positive or inspiratory effort. If we look at the expiratory phase, we see some noise in there for sure, but we see a couple of breaths right around the 6 and the 8 second mark. They look like an extended, a long expiratory time. So that means a long time constant. So we could probably infer that this is going to be expiratory resistance, high expiratory resistance. So expiration takes more than about a second and a half. So any comment about that? Any disagreement there, Ari?
Nope, not so far. But I would add that the capnogram also have the typical waveforms called the shark fin.
Ah, yes. Thanks for pointing that out. We don't often have CO2 waveforms, but the shark fin, it looks very much different than a rise and a plateau. So that indicates that we have multiple lung units that are emptying at the same time, and that's usually because there's different resistances throughout the lungs. So that's sort of a COPD capnogram, wouldn't you say, Ariel?
Yeah, I agree. There's no comments about that. Yep.
Okay, so let's look at our patient ventilator discordance situation. Looking first at the trigger event. Is it normal, early, late, false, or failed? Looks late. Okay.
Sal is saying like it looks like late.
Do we have any other observations?
Nope, that's the only one so far. Megan says normal.
Okay. Well, you know, it's a matter of opinion, I suppose, but look at how far the pressure goes down before it's triggered. So if this is, you know, if this is 20 to 10, this is something like, what's the PEEP on this patient? Can't tell, but the PEEP is something pretty high. And look how far below the PEEP the airway pressure has to drop before the ventilator triggers. And that takes a few milliseconds. So we might assume that even though this is set for flow triggering, the flow trigger sensitivity is too insensitive. It's low sensitivity, or the trigger threshold is too high. So I would agree that's probably a late trigger. Now, you might look over here and say, well, what's this curvature in here? Is this a failed trigger effort? Well, I don't think so. And we're going to get into that when we get to the cycle variable. Most of the time, what we see is pretty much an exponential curve, but it's a long time constant. We'll come back to this in a minute. What about inspiration? What's the level of assistance here? Would you say this is an acceptable level? Is it over assistance or is it under assistance?
Megan says normal. Well, regret and said under assistance, ourselves are under assistance.
Yep, and there's a possibility of auto PEEP, and that may be making triggering difficult.
Yes. There is a comment by Steve saying that there might be auto PEEP present on this patient, making triggering more difficult, which I agree.
That's a fact. That's a fact. So what that does is that it causes extra work on inspiration for sure. And so the question now is this under or over assistance? Okay, well, there is certainly some work shifting, right? Because we know that the patient's making an inspiratory effort. There's PEMA, so there's work shifting. So the question is this an acceptable level, or is it over assistance or under assistance? Now, my assessment is it's probably acceptable work shifting. Why? Because we have a target of 450, and that's pretty much what we're getting. If it was under assistance and the patient was making extremely large inspiratory efforts, then we'd typically get a high tidal volume and a very low inspiratory pressure. Why would the pressure go down? Well, because again, this is adaptive targeting. But still, for most of inspiration, pressure is above baseline. That means the ventilator is doing work on the patient, giving the patient some assistance. Patient is doing some work, so we got PMUS and PVent, and we have an acceptable tidal volume. So the patient's probably doing an acceptable amount of work. And of course, you would have to add in some clinical signs to make a final verification of that. But that's what I would say by looking at this. What do you say, Ari?
Yeah, it's pretty much what they are saying. A question, the difference between the ideal pressure waveform and this one that has a little delaying the rise. That it means that there might be some work shifting or the vent is not pressurizing properly.
Well, first of all, we see a slope on this pressure rise, right? And I do believe on this ventilator, you can set an inspiratory pressure rise. Is that right, Ari?
Yes, it is.
So if you have a very short pressure rise, the pressure will rise immediately right up, even if there's an inspiratory effort. So the pressure rise is probably set to make that slow. And why would you do that? If for this kind of patient, I probably wouldn't. Then the other thing is we see that once the pressure reaches its target, there's a little dip, and that's probably because that's the peak of the inspiratory effort. But then as the inspiratory effort drops off, the pressure rises again as the PMUS relaxes. You remember those first two slides that I showed, first series of slides, and now we're going to get into this issue over here where we have an inspiratory hold maneuver. And you can tell that because this is the vertical line. We see flow drops to 0, and the plateau pressure is represented by this. And this little sign means that the screen is frozen. You can move this cursor around and see what the airway pressure is. In this case, the airway pressure would be what, 26, right, Ari?
I don't see what it looks like. I think it's pretty close to the peak pressure if that is the peak measured by the vent.
Yeah, well, we can't really tell. The peak pressure is 23, but the plateau pressure, as according to this graph over here, it's 26. So the plateau pressure is higher than the peak pressure that we see over here. Probably let's assume that the peak pressure of 23 is what the vent is trying to target. But when you do an inspiratory hold and the patient relaxes, plateau pressure goes above that. That indicates now that the patient is adding the tidal volume on top of what the ventilator is delivering. So that's just another indication of how plateau pressure is indicating that there is an inspiratory patient effort. Okay, I think we beat that to death. Any other comments on that?
There is a comment by Steve. He said that the P mask maybe 10 centimeters of water negative, which might be excessive and lead to chronic diaphragm muscle fatigue. I think he's referring to the pressure muscle in. The pressure of minus 10 centimeters of.
Where does the 10 centimeters come from? A rate of 29. Yes, the rate of 29 represents that the patient's making a lot of inspiratory efforts. So there again, it's not just the effort or the work per breath that's important. It's the number. It's basically the power output of the muscles over time. So that could be a concern. So again, there's a lot of clinical factors involved. In fact, and also you'd want to look at the patient, right? You want to put your hands on the patient, take a look at what the patient, as the patient in distress, are they diaphoretic? Are there any other indications that the work might be not of acceptable level? So again, just looking at waveforms, it's difficult to say that there is under assistance in this situation. It's certainly not under assistance in the sense that airway pressure drops below baseline, so it's not severe work shifting. Okay. Any comments on that, Ariel? Have we interpreted that?
Megan is saying if the elevated plateau pressure indicates air trapping.
Well, it indicates that the tidal volume is larger than a passive tidal volume. So air trapping and pressure control for a passive patient just decreases the tidal volume. If the patient makes an inspiratory effort on top of that and relaxes on top of trapped gas, then yes, that will elevate the plateau pressure as well. So it's a good observation. There's a lot going on here, right? So when you think about plateau pressure and the effect of auto peep, you got to figure out how it affects the plateau pressure. So auto peep in and of itself, it depends on the mode. In volume control, auto peep will increase the plateau pressure for a passive patient. And in pressure control, auto peep just decreases the tidal volume and doesn't necessarily affect the plateau pressure, depending on whether or not flow has time to go to zero, like we said at the beginning of this. So these are good observations. I see everybody's thinking hard. And what all this tells you is that just pressure control is way more complicated than volume control.
So Rob, can we
Yeah.
say if there is no auto peep or total peep is equal to set peep, that the pressure plateau equals to the total pressure, the P vent plus P mask?
Yeah.
Am I wrong?
Yeah, that's true. That's true.
But that's an inhalation hold.
Yeah, that's an inspiratory hold. So you're not going to see auto peep on an inspiratory hold, but the auto peep has an effect, like Megan pointed out. So
Yes,
it was
and
there at the beginning of the breath, right?
yes, and also trying to make an expiratory pause on this active patient is pretty impossible
Yeah,
unless figuring out the level of auto peep could only be possible if we have an esophageal catheter and we can see the deflection on the esophageal pressure until flow starts.
yeah, that's true. It would be difficult to get an expiratory hold on this patient that is breathing 29 times a minute and triggering every breath. So good luck with that. All right, so let's move on to the cycle. Do we see normal, early, or late cycling? And where would we look to determine that? Late cycle.
Yeah.
Megan says late cycle.
Yes.
Any other comments on that? Inspiratory effort ends before machine cycles off. Well, let's see if that's true. Where do we look to see if the inspiratory effort continues beyond the cycle event? What's our key indicator there?
Well, the pressure waveform.
Well, the pressure waveform is only going to tell you when the ventilator stops. But if the inspiratory effort continues beyond the cycle time, which is indicated by the pressure waveform, what then gets affected?
Well, the flow wave.
There you go. So what we want to look at is the peak expiratory flow. So if the P-mus extends beyond the set inspiratory time, then it's going to distort the peak inspiratory flow. And we see that because the peak inspiratory flow is all over the place, right? Here is down. So an inspiratory effort that continues in the expiratory phase will cause the peak expiratory flow to go towards zero, particularly with this one is distorted. So like I said early on, this is probably not false trigger. This is just the P-mus extending into the expiratory time and then relaxing. So when it relaxes, then the expiratory flow increases. And so it might look like a false trigger, but probably not given all the other things that are going on. Yeah.
So based on the last graphic, when we have a very nice plateau, do you think that the P-mass is extended beyond, because it looks pretty relaxed?
Well, not for that particular effort, but you can see that these flow waveforms are distorted clear up to the time when the inspiratory time ends, right?
Yeah.
We don't get a nice exponential decay. The flow is still elevated at the time that the inspiratory time stops. So, at least in this particular breath, I would say, yeah, that's probably an early cycle. Now, that's not indicated by the inspiratory hold, but you'd probably want to see that on an expiratory hold anyways, wouldn't you? See how big
Yes.
the mus is. Anyways, that's my thinking. What would you say, Ari?
I totally agree with you. Description, it seems like the patient relaxed. To me, certain people say that it could be late cycling because in my interpretation, it could be that the inspiratory effort ends on the middle of the breath, followed by the relaxation of the inspiratory muscles. So the pause, it was made in order to evidence that sometimes that could be confused with the patient opposing the increase on the peak pressure at the end of the eye time. But the pause reflects that it seems there's some sort of relaxation. And in that case, it makes sense when people say that it could be late cycling. But it's hard to interpret because we need to be at bedside or see at least a PMAS tracing.
Yeah, and the other thing, just instituting an inspiratory hold can cause the patient to relax. What did Megan say? It popped up and it was so long I couldn't read it. There was a comment by Megan. Could you tell me what it was, Ari?
Yes, they see that she said that she can see early cycle now that she's looking for the waveform. Do you think it's causing the symmetric deflection of the pressure waveform that was here?
Up here?
Yes.
Well, I think the pressure waveform goes down because there's an inspiratory effort, and then I think the PMUS starts to relax, and then the pressure starts to go up, but the PMUS is still positive. Even if the patient's relaxing, if you still have a PMUS, a positive PMUS, you're still going to have an inspiratory effort affecting the flow waveform, and I think that's what we're seeing here. It would be so cool if we could actually have the PMUS waveform in here to show us, or an esophageal pressure, or maybe an EDI signal. But without those signals, it's kind of a guessing game. At any rate, I think that's as close as I can get it. Let's go on to expiration. Do we see any sign of expiratory work? I mean, remember, expiratory work means a negative PMUS, which means that it's forcing the expiratory flow to be more negative, be higher in the negative expiratory direction. Or do you think this is normal, more or less passive exhalation? Any comments?
No comment so far.
Well, I'm reading this as more or less normal.
Yeah, I would say relax. Yeah.
More or less normal. Okay. There's certainly no massive expiratory effort happening here. So, okay, that was a pretty complicated example today, and everybody did quite well. I'm really happy with the comments. I would summarize our findings today is that the key message here is that the plateau pressure is always going to be affected by tidal volume, and the plateau pressure is not necessarily the set pressure in pressure control mode. In pressure control, the plateau pressure could be equal to, less than, or greater than the set peak inspiratory pressure above PEEP. It just depends on whether or not there's an inspiratory effort, and whether or not flow is able to decay to zero before the inspiratory hold. So the thing that you want to be aware of in a take-home message is that an active inspiration causes the peak pressure to decrease with adaptive targeting. Remember, that's an indication of work shifting. But if the airway pressure is above PEEP for the most of inspiration and the tidal volume is still in a safe range, then I would say it's probably acceptable work shifting. We do not yet have any metrics that can help us at the bedside to know whether work shifting is acceptable or unacceptable, except in these stream of cases when the pressure waveform gets sucked down below PEEP or the tidal volume is in an unsafe range. So we are at 2:31, and I'm going to close this session. I want to thank you all for joining us today. Here's your QR codes for a credit. Send us your waveforms. As always, we like to see these waveforms coming in from the viewers, and particularly if they send them in with comments, that's very nice. And again, to remind you that we would like you to sign up for the SEVA courses. We have 3 online courses and 3 in-person courses. There are 3 credentialing tracks. There's the fundamental certificate, there's the advanced certificate, and there's the master certificate. The master course is called, this is offered twice a year in April and September. It's called the SEVA Summit, and we would like to see you there. With that, I'm going to stop sharing and say adios to all of you.